A lot of the women, I want to say probably 90% of the women that I screened for this study, they had the mindset of this is like only gay men can get this.
Unfortunately, we do see with the epidemics of HIV in the United States that there is not enough awareness. We're not doing a good job.
Do you feel like there's an adequate representation or awareness of just the amount or percentage of women that are impacted by this?
I don't think there is. This is why then there is that lack of access, but also stigma.
Everybody is welcomed here. And I think especially with everything going on, it's really important that women and everybody feels safe going and talking to their healthcare provider and being honest.
You're listening to the Men's Health Foundation podcast. I'm David Watson.
And I'm Marcus Boso.
Men's Health Foundation is a nonprofit healthcare provider for all men, specializing in gay men's health here in Los Angeles.
Each episode, we welcome members of our care team to discuss trending topics in medicine and wellness to help you take charge of your health.
Today in the United States, about 25% of the population living with HIV are women. About 20% of new cases in the US are women. And at Men's Health Foundation, we've historically focused on HIV treatment and prevention. That's how we were founded, HIV treatment, prevention, and research. And, recognizing Women's History Month and those statistics, we absolutely want to make sure that we spend enough time talking about women and HIV, what the options are today and what the options might look like in the future. And we're lucky today to have three great guests with us to speak about this. This is a new record for us. We've got Erica Kill and Ashley Toomey from Mills Clinical Research. Thank you so much for joining us.
Thank you for having me.
Thanks.
And we also have our staff physician, Dr. Manuel Pardo. Thank you so much for being here.
Absolutely. My pleasure.
So getting things started, I wanted to make sure to first discuss Mills Clinical Research, what that does, and the role that Mills Clinical Research has as far as being a resource for women who have concerns about treatment or prevention of HIV. So how would you maybe describe that to folks who aren't familiar?
So we have studies that emphasize on STI treatment and prevention, specifically with HIV. Recently, we had a study for PrEP that they allowed us a certain amount of participants to screen, but those participants had to be female, AFAB, and we weren't able to screen for male participants until a little bit later. And they really emphasized on female recruitments and are trying to bring more awareness into the female population with education on HIV and HIV prevention.
I think it's really important for women to be included in the research because it wasn't even mandatory for women to be included in research until like 1993. So it's now mandatory for a certain percent of each study to have female inclusion and women included in the study. And that's just creating like a representation of how that medication works for them. Since women have different attributes, like they have hormones and everything going on that are different than men. So being included in these medication studies, it makes it so that we can accurately say how that medication is going to affect women in the future when it is approved or rejected, whichever one.
Oh, that's wonderful. So I think it's also really clear that while being a partner with Men's Health Foundation, that Mills Clinical Research is absolutely actively recruiting women participants in clinical trials.
Oh, yeah. And we put an emphasis on recruiting different ethnicities and races in our clinical studies. So we try to reach a broad spectrum of not only females, but diverse populations.
Sure. And I mean, talking about the statistics earlier, also, of course, along with that, just as it's true for gay men, HIV disproportionately impacting communities of color in the United States with new infections and with infection rates nationwide. And I wanted to make sure to ask you, Dr. Pardo, with your experience with infectious diseases, your focus on HIV, what have you observed as far as just those trends, as far as the level of awareness of women's risk with HIV and, how that has been something that you've observed or not over the years?
It's a very important question because unfortunately we do see with the epidemics of HIV in the United States that there is not enough awareness. We're not doing a good job. Women are at risk, and women are now leading the infectivity rate in the United States. We may live in a bubble community like in California where there's women who are more knowledgeable, perhaps. Either they are have more access to PrEP, and or they admit the risk and or are aware of the risk and have access to PrEP. But definitely when you see the demographics of what's going on in the United States, it's more so on the southern states. So the Bible Belt, excuse me, and Florida have been the areas that are the hot topics of unfortunately HIV transmission, when we have such significant great medication that we can prevent HIV. So that is very, very sad, and sometimes even embarrassing to see that there is not enough coverage and or access to PrEP for not only this woman, of course, but also like all communities that should not be left behind. So I think that what you described before of the inclusion of the studies, it's of prime importance, and we heard of that diversity, equity, and inclusion. Like DEI, it's a trigger word now with what we have, but that is so important that we are including women, because it's a community that we cannot leave behind, and then we should study it more specifically in the United States.
Why do you feel like that there hasn't been an adequate focus on that so far in the conversation?
When you say the conversation about including them in research,
Maybe
or
just awareness of the rates of HIV infection in women, of just how 25% approximately of the population living with HIV in the U.S. are women. I feel like, Mark and I were talking about it. I feel like a lot of conversation around HIV is focused on gay men, whether that's in stories told about HIV or media coverage. Do you feel like there's an adequate representation or awareness of just the amount or percentage of women that are impacted by this?
right? I don't think there is. This is why then there is that lack of access, and or more so the patients themselves, either knowledge, but also stigma. Remember of how the stigma is also like so important, and even in the communities that I described before, of like either being associated to a characteristically and stereotypically known to be a gay disease, be part of like a promiscuous disease. So they don't want to be associated with that, and that is a challenge that culturally has been ingrained in the society, like the feelings and the perspective of that, have embarrassment to reach a sexual clinic, have the embarrassment to be stigmatized as a promiscuous woman, and not knowing the risk, and there's sufficient data that shows that it's not only about frequency of sex. You only need to have one sexual encounter where you're going to be HIV positive. And we want to prevent that. Again, I could not highlight enough of how good medications we have that are so effective and have are so safe, that it should really be implemented, or those persons who are at risk. So identifying those women, make them understand that they are at risk. It is an important first step for them themselves to reach care, because there's no other medication. The best medication that there is the one that the patient takes, because you can prescribe and offer something, but if the patient is not going to take it, then well, that's not going to be a great medication, right? So we need options, and we need more options for each one of the lifestyles of women. And that's an important one to understand. And there's more research being done about it, and there's more work to be done about like what other options we have specifically for this subgroup of community of patients at risk for HIV.
And speaking of, specifically women at risk for HIV, and going back to the clinical trial you were talking about in this clinical research, what's been your experience in the women that you've been talking to, prospective participants or participants in your trial? What have you observed? What surprised you about what you hear about, their own perceptions of HIV or their own awareness of HIV?
When screening for this PrEP study, it's an injectable PrEP. A lot of the women, I want to say probably 90% of the women that I screened for this study, they had the mindset of this is like only gay men can get this. And the education around HIV was very limited. I think I had a discussion with one of my participants about how sexual education in the United States is not the greatest, and how for females specifically, sex health is kind of emphasized with reproduction and not a lot of STIs and HIV, and it kind of shows when I am speaking to them because they were like, I didn't even know I could get HIV, and explaining to them that anyone that has any sexual encounters is at risk for HIV, and also explaining how there's other ways to contract HIV, IV use, so many other different ways. Even like in a clinical setting, you get a finger prick, you're at risk for contracting HIV. And I think with this new study, it's an injectable every 4 months. It also helps with the barriers of access. So you don't have to take a medication every day. And you can come in every 4 months and get an injection and then move on with your daily activities and not have to think about it in the back of your head.
I think the injectables are very like a very important advancement that we're doing right now with research, not even for prevention, but for also treatment. So a lot of the stigma comes from women being scared to take the daily medication or people seeing them take that daily medication. Partners of theirs, like they don't want people knowing that they're doing that. So if we can implement injectables where they come into the clinic they can say whatever they want to say it is, like an annual physical, and they get their injection and they're okay to go. Like that really decreases the amount of anxiety around taking that daily pill and having people see you take it. If that is one of those triggers for women that keeps them from getting treatment or taking PrEP. And there's just been so many women that we've talked to that didn't even know about PrEP or didn't think that they needed it. Statistically, there's not a lot of women taking PrEP that could actually benefit from it. I think it was like 15%. So there's a lot of education, I think, behind prevention for women that needs to be done to be able to get women up to where they should be prevention-wise.
Wow. It's interesting to hear that. I mean, even in LA, even in 2025. Dr. Pardo, I wanted to make sure to ask you as a physician, when it comes to PrEP and women using PrEP, is there any particular concern, whether it's a daily pill or with injectables, with women taking PrEP versus men, cisgender women?
Yes, the biology of it is very important for us to understand. When it comes to HIV contraction, anal sex and vaginal sex are very important because of the way that medications work and the concentration that are needed in these specific tissues. With women in particularly, the vaginal sex, the vaginal tissue, the mucosa of the vaginal tissue, it's a little bit harder to penetrate on some of the oral medications, and women need much more of a better adherence in order to get that major protection that they get. So that's what we saw on the clinical trials of the oral medications like FTC and FTAF, that women needed higher intake of the medication. And it is interesting to see, I always get surprised when I see the clinical data when women were being studied for PrEP, to realize or to know that women unfortunately were not as adherent as men were, which actually, as I just explained to you, they are the one particular patients or group of community that needs to be much more adherent in order for oral PrEP to be effective. So when you have now these long-acting medications, that's how you see the impressive superiority with women compared to men, because then we're not relying on the intake of the medications by the patient on a daily basis, but you are only just giving the shot, and then that's it. You don't have to worry about that because you need to come back for your next shot in whatever long acting is the one that you're taking. At the current time, we only have one long acting, which is cabotegravir, and you do it every 2 months. But there is like new things coming up on the pipeline that would be giving longer shots, up to like 4 or even 6 months, sometimes even a year coming. So this is a very, very important topic of research right now for HIV prevention, because when we overcome that need of compliance of the medication, and we have such successful new medications, long-acting medications to give to the patient and to get protection against HIV, it's going to be a game changer for the control of the HIV epidemic. And that's our goal. That's what we do as HIV providers. Is the number one goal is avoid any infections. We have these tools that are very successful to control HIV. So like we definitely want them to provide them the best of care. So one HIV infection is too much infections. We want 0 infections.
And to make sure that people are aware who are listening, may be interested, cabotegravir, is that currently available for anyone to access in the U.S.? Do we know?
Correct.
And would you suggest that, I mean, if the daily pill was really a more accessible option or a more affordable option, would you suggest that in that case? Do you think that would still be effective for women and a good idea?
If it's definitely effective, you just need to really enhance the need of like make the message of like the real need of like good compliance of the medication, specifically in the woman population. But yeah, like the data show that definitely long actings has been way more successful, but it's actually in both men and women. But all of that just comes not that because one works best than the other, but it is more so because of the compliance of the medication, and then we see that on clinical trials. There still could be rare breakthrough infections with the use of these medications, but they're definitely rare. As long as the patients come as it is scheduled for their shots, and or if they take the medications orally, then these medications are still, regardless, highly efficacious and very safe.
Great to hear. And I remember too, I wanted to make sure that we ask about that you had gone to CROI recently. If you could just help listeners understand what that conference is, and then maybe some of the things that really stood out to you when you were there, some of the exciting things happening.
Well, there's a lot of exciting things for sure happening on HIV. One of the on HIV medicine.
Sure.
There's a lot coming for prevention and a lot coming for treatment. For prevention, I was just stating a little bit of like there's a new medication called lenacapavir that is coming, that is going to be a shot every 6 months. We expect and hope that it's approved by the FDA in June. That's the hopes that we have. Very compelling data where there was in women actually the very first PrEP medication, but it had 0 infections, no HIV background infections in over almost 2,000 women that were included. Yes, they were all in sub-Saharan Africa. They are doing a study right now on lenacapavir specifically for U.S. women, because that's a niche that we do definitely need to do. Like sub-Saharan Africa have their own statistics, and then we definitely need to study different regions. So we want to need to have the studies done in American women to see if that also translate as good as like it translate in sub-Saharan Africa, but we expect it to be that way. So that's upcoming. There's actually also for those women be like, and this is something very important because it actually happens on gay men. So like, well, you know what? When you come to a patient, be like, I am sexually active, but not that sexually active. Why do I want to be on this medication every day, or like getting a shot when medication is running around my system? So in gay men, we use something that is called PrEP on demand, and it's called 211. And for those patients that I usually tell like have less than 2-3 sexual encounters per month, then you can do that as a strategy. So, and that's actually called with TDF. type of MTC, 3TC, which is medication. When I use the name Truvada, is generic now. But now there's also research of studies specifically knowing for PrEP on demand specifically for women, and because we know, and I explain you the biology of the access of these drugs into the vaginal tissue. But they're starting to do PrEP on demand on women, but doing like instead of 2-1-1, it will be 2-2-2. So it will be higher doses, so 2 tablets every day. So before the sexual encounter, and then 2 more for a couple of more days, like 3 or 4 more days. So that's data that's still being collected to see if it's as efficacious. So that is helpful because we need options. When you go to a restaurant, the more options you have, the happier you are. So we are studying that. So I think that is an important niche of research to know and give an option also to women who don't feel that they're at a risk as much, and they don't want to be on a medication all the time. So that's the exciting thing that is happening about PrEP right now for women. There is newer medications, new capsid inhibitors, also 1 pill a month only. So that also everything is studied in both. But then the studies for PrEP need to go definitely. One is for cisgender women. Another one is usually designed for men who have sex with men and transgender women because of vaginal versus rectal tissue. But those medications are studied for both, and we need options, and then options are coming.
Okay. That's all really exciting, and I saw you nodding a couple of times. It sounds like those are maybe some trials and some new things coming down the line that you'll have been familiar with in Muskoka research too.
Yeah, definitely. The lenacapavir study,
Yeah.
we are part of their MSM study, but we received a lot of clinical data from their original study, which was done in Africa on cis women, and the data looked very promising. The adherence for oral medication was very low, and the success rate for the injection was very high. And I believe it was around 4,000 women that they tested this lenacapavir on, and a lot of positive reports came back from the original study.
What do you think as far as the patients that you have here in LA and in the US, or, trial participants, I should say, what are some of the most promising things that you're seeing as far as when people get engaged with clinical trials? What kind of difference do you think that makes in their attitude toward HIV? I mean, what kind of a change do you see happen for people that, get involved in this way?
I think the biggest thing is awareness, being presented with information about HIV and the risks of HIV. I think that is really huge. And then also it brings up a curiosity of other infectious diseases or just their health in general. With clinical trials, we do a bunch of labs and safety labs, and a lot of our participants, they'll come in for their follow-ups and they're like, oh, I didn't know this certain level is high, I should go see my PCP. And it almost reinforces a positive outlook on getting care. And I think it's a huge step into, almost in a way, to self-care, and making that step to, this is important medication that I should be taking, and it's like a route towards self-care. And it also helps with a bunch of barriers. Clinical trials, a lot of clinical trials will offer stipends, lift rides. So some women or men in general, they don't have access to healthcare. So it's a great route to get the basics of your healthcare and a way to monitor it.
Sure. That's wonderful to hear too. It seems like it can really, make a difference in people's lives going forward and their health. From that point on, what have you seen, Ashley?
I mean, I've seen a lot of the same things. I think one of the main ones is also like the barriers to care. It kind of eliminates a lot of those. And they're able to work with people a lot more than like a regular clinic would be, just because they like to help people get to their research visits. They help them with the stipends. And you don't need insurance to be in research, which is a big one. So a lot of the population that's uninsured and wouldn't be able to get care otherwise, research is a good option to kind of look into for them to see if there's anything they're interested in, because it can kind of take out that stress of like, how am I going to get my medications? How am I going to be safe when I can't afford to pay for all of these? Because without insurance, like HIV medication, all of that is pretty expensive, and there's programs that'll help you sometimes get it, but research is always a good option for them for that. And then as well as during your research visits, we usually have a lot of time. We can kind of set aside a bigger chunk of time to sit down and talk with them, make sure that they have any questions that they have answered, and they have a chance to talk with a doctor every time they come in too. So most visits, they'll get a physical, especially if they have anything new come up or any new health issues. So they get direct access to a doctor, and then they get a lot more frequent labs than they usually would going to like a regular clinic, just because it is a research trial and we want to get more data like that and make sure everything looks okay and make sure everything is going well for them. So you get to see a lot of different labs that you wouldn't normally get that often too, which is kind of nice.
How long does that process usually take?
Some trials are like a year, but some trials can be up to 2 years. Like I think our PrEP study is going on 2 years right now almost.
Yeah, I think our lenacapavir study, I think we're hitting that 3-year mark.
And that's depending on the phases too. So like phase 1 studies may be a little bit shorter, and you may take a different dosage of it, and you may only take it once, and then you phase out of the study. Phase 2 studies may be a little bit longer, and then phase 3 is usually the last phase, where after that it gets to go to the FDA. And during the time where you're waiting for the FDA to either approve or reject it, most of those studies will allow you to stay on the medication and come in like about every 3 months is what I've seen, just for routine visits to get labs done, check in with your doctor, and get the medication so that you can remain on it too, and you don't have to switch back to another one while you're waiting for it to be either approved or rejected.
Oh, great. Dr. Pardo, in what instances would you recommend for folks, like patients that you see, to get involved in a clinical trial?
Because we have the pulse of what's going on here, particularly in an organization, then we tell them what, if there is an availability, if we think that is a candidate, like any research protocol has like their inclusion and exclusion criteria. So we are aware of what's going on, and then we identify any person who is a good candidate for as a participant. Then and if they're ready to volunteer, it's a very altruistic way to, when you really put a research participant, because it really helps to build up science and build up the knowledge that we do have. So if we see that there is a person who can who was willing to participate and is willing to answer the specific question, that is something that you really want to address. What is the scientific question that we do have that you want us to help us address? And then making them understand that that they also will get a benefit out of it, we hope and we expect. Then that's what we address on identifying these subjects to be put on research.
Oh, I think one of the things that really stands out to me right now that I want to make sure that I ask is, what do you think is coming up next as far as where we're at in the U.S., as far as availability for HIV care? What are some of the suggestions you might have for people to make sure that they are getting the access to the care that they need? What are some of the issues maybe that are on your radar for access to care for women, maybe specifically for HIV or, medical care in general?
With our rapid results clinic, I've seen a lot of participants come in just for routine STI checkups, and an emphasis on, if you're sexually active, routine checkups. And then during those visits at rapid results, they receive a lot of education from the provider, and they'll do routine testing. And also if they identify any risk factors for HIV, then the discussion of PrEP comes in, and then participants or patients that are on medication, they get to stay up to date with any new medications that are developing. So I think, awareness is huge in that.
Ashley?
I think it's important also that the foundation really creates like a safe space for women to come in. Like, it may be named the Men's Health Foundation, but it's always emphasized that like everybody is welcomed here. And I think especially with everything going on, it's really important that women and everybody feels safe going and talking to their healthcare provider and being honest. It's so important to be able to be open and honest with your provider when you talk to them, because if you withhold something important, it can really like set you into like a dangerous area where you might not get diagnosed with something that you could possibly have. You might not be able to get the proper treatment because they're not aware of everything that's going on. So I think that's one of like the main important things I would say, is just that they're able to feel safe and feel like they can talk to the people where they're going at the healthcare facility that they're getting care at. And I think Mental Health Foundation is great for that. I mean, I've seen so many people come into Rapid Results and then end up getting linked into care, like helping them get insurance. We have so many programs here that like help them with each step of the way to get to where they need to be. And I think that's like cutting out a lot of the barriers too. I mean, we have assistance with like Lyft rides I've seen to the primary care for some people. They have so many, and they help you with anything that they can. So they like walk you through each little step of the way. So it doesn't really just stop at like, I hope you can get help, like send you out.
Right.
They're very involved in getting you in and making sure that you are taken care of and that you understand everything very well and that you feel safe where you're at. So I think that's a great one for here.
Oh yeah. And Dr. Pardo, on your side, on the clinic side, and as a physician, have you seen the same thing as far as just the importance of patients feeling safe so that they can, share all of their concerns in a judgment-free environment? And do you think that at Men's Health Foundation, have you seen that more than in other places?
100%. And that's actually one of the successes that we have as an organization. And I want to publicly thank Erica and Ashley for being part of the face of the organization, because as I said before, it used to be kind of like it's just like a gay man's problem in America, but that's really not the case. And the fact that you can identify with woman, in this case, with a gay man, with a color doctor or a woman of the same gender, that actually gives like a significant latch onto like safety and a sense of connection. And just like you are definitely empowering women to seek care in this organization, despite the men's. We need the WO there in front of the men's. Wow, women's health, because we look. I will tell you this: there in all of the fields of medicine, there is not field where you are going to see on HIV medicine the most importance that we do care of not leaving any community behind. And that comes again with the DEI. All of the clinical trials are intrinsically important that they include every single population: men, women of color. We had that women of color, transgender woman, gay man, cisgender woman, all of us, because we need all of us are actually at risk. So we need to understand everything. And we one of the things that we had at the beginning back in the 90s, a lot of the patients were mostly white men, and that's it. But that has really changed, and there's been a significant push and a need and a must that we should enroll diverse population, because we need the data for that. We cannot just extrapolate from one population to another. It's not fair, and it's not safe. So science comes from truth, and the bridge to that is this clinical trials and creating these large, expensive trials. But there's actually what actually give us like the real information, so we can actually give solid recommendations to our patients. So that's the biggest point. And to your point of like what else can we do as our organization to provide that, is like access to these programs and then engage them in care is very important. To see that we are interested in their well-being, it is important. And I don't want to sound grim with what I'm about to say, but we live in a reality with there's extremely anxiety of what's going on with the administration, where a lot of these programs may be at jeopardy because they do not believe on the diversity, the equity, and the inclusion. And when that happens, all our community is put at risk, because when you do not put patients in care for either HIV treatment and or for PrEP, for prevention, then I don't need to tell you what's going to happen. I mean, the rise of the morbidity and mortality, new infections with HIV, and or people who are with HIV will have like an advancement of the disease, and that will be so detrimental. So I will. My message to the audience is, don't be fearful of like asking for care, and this is a safe space. And fight for what you need and what you want and what your rights are, and then health is gonna be like a blanketed right for absolutely everyone, no matter colors, genders, race, political status, nothing. Everyone should be the right to health. So like, you see us as a friendly foundation that wants just the best for you, and fight for your rights. We need to resist.
You are your biggest advocate, and with that does come with a lot of weight. Just know that there are a lot of providers who are right next to you, supporting you. There are a lot of programs out there, not just specifically our foundation, but many other facilities that are wanting to help out. And you just need to take that first step and seek either a PCP, regular checking for STIs, anything like that. But there's a lot of people in the medical community that want and will support you through anything health related. Yeah.
I agree with that too. I think one of the main things is like the barriers to getting care are very real, and people know that. Healthcare workers know that. And if they don't, they should. But I think one of the main things to keep in mind is stigma really sets people back from getting care. And stigma is it's very dangerous. It can be life-threatening. It can create large gaps in healthcare. And I think one of the main things that people need to remember is just stigma is real. And as a healthcare provider, I think it's kind of your job to educate yourselves and combat stigma with proper education, making sure people know the real facts, making sure that people feel safe coming to your space and coming to talk to you and see you, and they don't withhold information. And I think with patients, when you go see your provider, if you have one, I think just remember to advocate for yourself like that, and don't let the stigma stop you from seeking the care that you need. Obviously, like, everyone's health is the most important thing, so you can't let stigma keep you from getting your health in check.
Well, Erica, Ashley, Dr. Pardo, thank you all so much for what you do. Thank you for what you've advocated for here today and the resources you're providing. Any last words before we wrap up?
Thank you for having us. And we look forward to all the new medications and programs to help build awareness around HIV.
Yeah, I will say the same thing. Thank you again, both of you, for all of you putting this together, and to the audience again. Like, it takes two to tango, and we are good dancers, so we're ready for you. You just have to, what you were saying, patients what they need to do is drop the stigma, drop the shame, drop the fear. Come here and get the knowledge. We have options for you, and come and get tested, get treated, engagement in care. This is all for your health, nothing else. You do you, but you really have to step up, get up of that chair of shame and embarrassment, and just live a healthy life. And we want you to live in and thrive with it. So that's my message to the audience. Get up and dance.
Thank you all so much.
Thank you.
Thank you.